Hey, everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways.
No, and I think if you stick to the basics and you do it correctly, and you're not hyperventilating that patient, then you're not going to see a lot of those complications such as increased interthoracic pressure, decreased blood flow to the heart, and then also, we haven't talked about it, which is your trigger word, gastric distension, right? So if we're doing this, then you know, if they had a Chipotle burrito, you're going to find out if they had fajita veggies or not, right?
Yeah, they're going to vomit.
If we hyperventilate them, and that's just another complication to your
always bag
skill.
This with this turn towards the physician.
And that's why your doc doesn't ride with
He stands at the door. Nope, Ferroni's on this call. I'm going to manage this one from the door.
You're doing good. You're going to do good.
We now have talked about that physiological implication of transitioning somebody off of negative pressure ventilation, which is how we're all breathing right now. As I like to think of it, it's the bellows effect, right? It's like I'm taking a set of bellows. When I expand the bellows, air from the outside doesn't just, magically shoot in there. What I'm doing is I'm making some negative pressure by pulling those bellows apart. That negative pressure, now air outside wants to equalize with that negative pressure inside, and it's trying to balance, right? It's just not just getting shoved in there.
It's a primer on your fire engine is what it is, the Venturi effect.
That is how we're all breathing, and that has some physiological, normal, every day, as we're sitting here, implication in our blood pressure, right? Mm-hmm. So that bellows effect, that temporary negative pressure, that negative interthoracic pressure, as I take a breath in, is actually sucking a little bit of blood back to my heart, right? And if you've got somebody that's already hemodynamically unstable, it could be very impactful. I certainly have seen it happen, right? We put somebody on a vent, start bagging somebody, and now you've transitioned them from negative pressure ventilation to positive pressure ventilation. You've lost that augmentation, and then also, if you're doing piss poor process with your BVM, right? And you're bagging too aggressively with too much volume, you also then could be squishing the inferior superior vena cava, and you've already lost the augmentation. Now you're doubling down on a crappy situation, and now you're
Doc
squishing.
said earlier, now you have no preload.
That's your preload,
you're making
right?
it worse.
Yeah. You've lost blood flow in, and like we tell the students, if there's nothing coming in, what's going out? Nothing, right? It's a closed circuit. There's nothing in between.
And for the EMTs listening who are new to this in med school, I kind of grappled with this because we all think of physiological as a normal physiological person, right? We all have normal blood pressures here. Where none of us.
Depends on the day. It's Tuesday. It's better.
None of us are, that I know of, hypotensive. We're not on the verge of shock. If I
That's
change
accurate.
the physiological, if I change the physics inside my chest and I drop my blood pressure a few points, it doesn't have an effect. It does have a huge effect if that systolic blood pressure's 80.
Already, sure.
Yes.
It's already piss poor.
Correct.
And that's what you have to think of is the patients are going to be thinking about taking an airway and are very sick, right?
Mm-hmm.
So they're not going to have normal physiology. They have bad physiology.
Yep.
They're on the precipice of that cliff that they're about to fall off.
Correct. They're about to nosedive.
And I don't want to go down this rabbit hole, but I want to say it here. Then in some cases, we add medications that also strip away vascular tone, strips away, their ability to spontaneously ventilate, strips away. We have to own all pieces of this. It's just not the good mask seal, the good there's the holistic part here, right?
You have a global approach. We're talking about
everything.
We're talking about this in smaller steps, essentially, but how it's a systemic change.
It absolutely
Correctly.
is.
And to that point, that our our RSI agencies have that added risk that you're giving those medications that are going to take away a lot of your tone,
Yeah.
if not completely paralyze.
Completely, right.
And that's going to complicate matters as well,
Yes.
with airways and with everything.
That would probably be the most extreme in our EMS case,
Yep.
right? But certainly if we were just using some Versed and some fentanyl, also impactful, right?
Yeah.
Ketamine should be less impactful in some of these, but
You should get better cardiac output because it's going to give you a little bit of
Ish,
tachycardia,
right?
But if the reserves aren't there to meet that demand,
it's
just
irrelevant.
not going to happen.
Well, and that's why we prioritize it, right? It's the safest of the things that we present to you, right? It's like, try this first. This is probably going to get you in the least amount of trouble.
And not to turn it into an RSI lecture, but the departments that are trained in RSI 3UH are using rocuronium and not succinylcholine. And it has a longer effect, too. So they need to be ready for that, and you need to be ready for that. And to know to keep those patients out of it during the paralyzation, because if you forget to dose that ketamine, there's going to be an issue.
This is this is great because we're talking about all of the things in preparation, which is where I was trying to steer this a little bit.
Before we go there,
Yeah.
some people, when we were using etomidate, and etomidate has its own contraindications in certain disease processes, sepsis being one of them, and can take away some of the androgen effects, not necessarily right now, but maybe in a few minutes,
Yep.
maybe later on in the care. So it's all
tied together.
That's a good
Yeah,
point, yeah.
right. Yeah, it's everybody thinks about it as a bunch of individual procedures or a bunch of individual things, and it's the cumulative effect that we have to be aware
The
of.
biggest differences between an RSI procedure and intubation on a regular patient is that RSI is something that I'm planning. I need to be set up and prepped and ready for that.
Yeah.
I
Controlled.
would say that both should be planned.
Absolutely. But if I'm intubating a cardiac arrest, it's a little more thrown out. It's a little more acute than the chronic RSI case. But there you go. That's what I'm getting at.
I will.
Done.
Airway is secure.
Done. And the same should be said for RSI if I miss it. You have backups.
If I can say that in my own words, the times you should be emergently intubating somebody are very, very rare.
Few and far between.
Like just running up with a laryngoscope in your hand and dumping a tube, right? That should be very, very infrequent, like once in a career kind of, twice in a career kind of situation.
I think the county has had one case this year.
Right.
So it's, yeah.
That really met those criteria.
That met it,
Yeah.
and they performed it. It went well. Everything
Oh,
was fine.
you're talking about RSI.
Yeah, RSI now.
I am talking about just willy-nilly coming up and
Oh.
and doing a hurry-up intubation, right?
Again, it's not usually
or a hurry-up airway.
like he said. That's your tool. This is your tool for that case
Well-
until you were somewhere ready.
I don't know about when you guys went to school. Certainly, when I went to school, it was it's like you were getting out of the truck and you laryngoscope and a tube in hand, right? Or at the end of the day, it was a combi tube, right?
You got nunchuck tubes.
Pretty much, right? I mean, that was kind of the. I'm clearly overstating this for dramatic effect, but the point is that you would run, you had to do that first, and you had to hit that hard, and you had to do it the big, you had to go with the most extravagant way, which was
Correct.
endotracheal intubation. Those cases where you just need to truly emergently take an airway. I mean, again, few and far between. Do something to manage
Correct.
quickly, yes.
Just work from simple to complex.
and then you work up.
Yeah, just start simple and then work to complex and ensuring that your patient is being oxygenated and ventilated as well as you can possibly do that. And if one is not working or going to be sufficient for your transport time, because we really didn't throw transport time into there as well, because even if you want to talk about BVM, eventually you are going to get some gastric distension for long periods of time, things of those nature. So that kind of goes back to, I think in EMS we're driven to, this is the checklist, and I'm big on preparation, big on checking your truck, and this is going to be the procedure for this, but this procedure also affects, to your point, the whole big picture, if you would, for lack of a better word, or there's a whole systemic effect from these steps. Because as soon as I complete those steps for the airway, back to your sepsis patient, maybe I need to do something else. Now I might need vascular access, and maybe I get into pressors, or am I given fluid? Like, they're still in the whole big systemic picture of what is really wrong with my patient, not just the airway.